test there, or I'm sorry, a pediatric disease. So let's just go down like this way, right? Of course. There you are. So with autosomal dominant polycystic kidney disease, you have an increased incidence of infections and calcs inside of these cysts, and that's I just realized right off the bat within 2 bullet points, I was going to say something that's incorrect. I was going to say stasis. You know, all these cysts sitting there, just static there, and stones precipitate out of them. But that wouldn't cause it because these cysts are not urine cysts. They are for the most part blood serum. All right, something I have to look up. But in any case, infections and calculi are increased with those with people with ADPKD. Also, cysts in the liver, pancreas, spleen, lungs, and a few others are possible. And berry aneurysms of the brain, which if those burst, that's when you say, oh, he had an aneurysm. My internet connection is unstable. Hopefully you guys hear me okay. I've seen a few Zoom meetings where the internet was not clean. It was hard to listen to. The other thing I could add to this is an increased incidence of renal cell carcinoma, interestingly enough, but we'll get to that today as well. And we mentioned medullary sponge the other day as well. It's a benign cystic dilation of the collecting ducts. Now I could definitely say stasis of urine for increased chance of calcs and increased chance of infections, both because of stasis of urine. So even though they're echogenic, that was not what you expect. But when we talk about very tiny cystic structures, those can be echogenic. Now, neither of these kidneys do I see evidence of calc. There might be some calcification in here, but it's not enough to shadow. So this person just simply has medullary sponge kidney. And it is named after the physical appearance of specimens. So if you actually pull the kidney out, cut it in half, it looks like a sponge on the inside. The medullary section, basically the pyramids, look like a sponge. Okay, and cysts, we talked about that the other day as well. I believe they should be anechoic, smooth wall with through transmission. There is through transmission here. It's not bright, but the whole screen is kind of fuzzy on that one. This one, either we can call it a thin septation or a kissing cyst. Now, like I said before, I learned, guys, that anything on the inside, even if it's one tiny thin septation, technically it is no longer a simple cyst. But your book seems to suggest that if it's very thin like this, it's still a simple cyst. So I don't know what to say about that. But yeah, kissing cysts are just kind of a term people use when you have two cysts right next to each other, creating what appears to be a septation when it's really just the two cysts laying together. A term I want you guys to know, we mentioned this the other day, is exophytic. 3 left kidney exophytic cysts, probably simple, but the image is plagued with too much speckle. So that's tough. If you're using older equipment, you're gonna have a real hard time getting a truly anechoic cyst. And that's a problem. There are doctors in this town who really, they want you to do everything you can to make it anechoic. And they want you to do this at, honestly, in my opinion, at the expense of the overall quality of the image and the ability of the image to show real structures that happen to be of low echogenicity. So I'm not for it, but I'm not the doctor. And so that's the spleen above the kidney there. And anyone notice anything else? This is what pleural effusion looks like. That is all fluid in the lung space there. So that's not actually lung, that's the lung space is filled with fluid. So that person has a pleural effusion along with some exophytic. Oh, and did I even mention what exophytic really even means? It just simply means on the outside. So exo, outside, phytic, I don't know what that is. But you could have an exophytic tumor, an exophytic cyst. It doesn't always mean cysts. Hemorrhagic cyst, simple cyst can bleed. So this may have been a simple cyst at one time, as well as this. No longer can call it simple because it's filled with some stuff here. But neoplasms, now some cancers are cystic. Not every cancer is a solid cancer. Some of them are cysts. But a neoplasm really means new growth. Cysts are not neoplasms. They're simple cysts are not anyway. But neoplasms are neoplasms, and they have blood flow to them. They are more likely to bleed, especially if it's cancer. They're more likely to bleed. So this is important to note. Chances are these were simple cysts, but since they've bled, that is more concerning. Man, I had a hard time finding really benign looking septations. Really hard time finding that. I found them in other organs, ovaries for sure, and some other organs, but on the kidney, very difficult. So thin septation, left image, slightly more complex on the right, but for the most part, fairly, definitely benign looking, fairly benign looking on the second image here. Well, it's just up here. That's a pretty thin septation. You can kind of see it go from wall to wall. Definitely something you mention to the doctor through transmission. Thin septation, low in cyst and thicker septation, high, possibly mural projection. So we have a thin septation here. And this could be a septation that's coming, I can almost see it coming around this way, perhaps, or not. It could just be a mural projection, something projecting into it. Well, if there's something projecting in from the wall, that means it's alive. I guess it's a way of saying it, alive, or neoplasm, some kind of growth. And those are also of concern. So not so benign looking cysts. Thick septation. Mural, this is a mural projection here. A very thick septation there. Down here, this is a simple cyst as far as I can tell, but this one has very thick septations, some other septations going on. Looks like multiloculated, so thick septations, mural projections, and Doppler. Look at that. If you find blood flow in a septation, that is definitely concerning. So this one is a renal ultrasound here. You can see the CT image of it. Very concerning. We mentioned these the other day, the parapelvic cysts. I think I already used this picture. This looks a lot like hydronephrosis. In fact, you don't know until you carefully scan backwards and forwards through this. If these connect at some point, then it's hydronephrosis. But if they never connect, then they're parapelvic cysts. I didn't even bother with the term peripelvic. Parapelvics are more like they're more like exophytic cysts that happen to go inwards, whereas peripelvic are truly pelvic cysts that start from the lymphatics. But like I said before, we don't really have to care about that fine difference between the two, because you can't tell on ultrasound. So why bother? That's weird. Why is there a? How did I do that already? That's weird. All right. It's difficult to this acquired cystic disease. So it's difficult. So I'm trying that. Nope. To even make out the kidneys in both of these images. That is end-stage renal failure for these. They are atrophic and echogenic. In other words, when a kidney is echogenic, it may, the parenchyma may start to look a lot like the surrounding fat, which makes them very hard to see, even when you have them straight in the middle of the screen. Acquired cystic disease also has an increased incidence of renal cell carcinoma. So both of these patients are dialysis patients. Dialysis, I looked it up. Actually, no, it is in the book here. No one really understands completely why dialysis patients create these cysts, but they do. Tuberous sclerosis. I think we mentioned this the other day. We didn't really get into it much. Disease affecting multiple organs. So you usually mentally retarded, and I believe the mental retardation actually comes from all these plaques, the sclerotic plaques on the brain affecting brain function. So there's varying amounts of mental retardation. The disease affects multiple organs, but almost everyone with tuberous sclerosis has something going on at their kidneys. So cysts and neoplasms all over the body, but angiomyolipomas in the kidneys. Now, you or I may have an angiomyolipoma. Those are not in and of themselves that unusual. But if you have many of them, like this one is, there's a lot of little angiomyolipomas on this one. All these little dots, certainly these two bigger ones, and yeah, probably those down there. Those are all indicators. I've just stopped to look, just so you guys, how a sonographer will sometimes stop and have to stop talking for a second and think about what they're looking at. I was almost wondering if I'm seeing a shadow come down here, but I almost want to say it's not a shadow as much as probably like maybe a little bit of refraction. I don't know, but it was really subtle. I don't know. Here, more angiomyolipomas. These are some larger ones, some smaller ones. Here we have an angiomyolipoma and a cyst as well. So that's tuberous sclerosis. As I said, multiple angiomyolipomas, multiple tumors in general on people with tuberous sclerosis. They actually have a defect in a gene that is a kind of a tumor stopping gene, and so increased cyst, increased incidence of renal cell carcinoma. Notice there seems to be a connection between a lot of these and renal cell carcinoma, a lot of these cystic diseases. Von Hippel-Lindau is actually really similar to tuberous sclerosis, I'm sorry, in that multiple cysts and neoplasms can occur throughout the body, and another increased incidence of renal cell carcinoma, but the tumors originating are in different tissues. And so even though it's all over the body, these tend to be spinal hemangioblastomas, retinal angiomas, so unfortunately a lot of these people go blind, pancreatic islet cell tumors, and pheochromocytomas, which we talk about probably not on Monday because that is a tumor on the adrenal gland, can cause a pheochromocytoma. Speaking of adrenal glands, adenomas, I could not find renal. It is the only picture of a renal adenoma I could find on the internet, because I put in kidney adenoma, renal adenoma, and every single image except for this one that came up were adrenal adenomas. And so gives you an idea that the adrenal gland is far more likely to create an adenoma. Adenomas of the kidney, if you ever do see them, you'll not know that it's an adenoma. You cannot tell that's an adenoma. We simply just know that's one of the differentials. They are benign in the kidney. Adenomas in general form from glandular epithelium. Oncocytomas, basically a giant vascular adenoma. These guys are benign, although they don't look benign. Main differential diagnosis is renal cell carcinoma. This looks like carcinoma. This just looks like a big old cancerous tumor. And notice this central stellate scar. Lots of tumors have a star shape in the middle of them. And a lot of times what that scar is starting to become necrotic in the middle here, because the blood is growing so fast it's outstripping its own blood supply, and it actually will die in the middle. But yeah, so in this one, there's no way you, the doctor, anyone who's looking at this would not say, oh my God, this person needs to go to surgery and remove that most likely renal cell carcinoma. And they get to surgery, they have it removed, and they find out that it's not renal cell carcinoma. And that's good though, because renal cells metastasize really badly. Another one that looks like, I'm sorry. So we're going right back to the angiomyolipoma. We've already talked about these in tuberous sclerosis, also called AMLs. Angio for vessel, myo for muscle, lipo for fat, and a really poor imaging job down here. They need to attend our lab. But I figured it showed a nice angio. This guy actually has a little through transmission. They don't have to have through transmission. This one, when I picked it up, this actually is a partially inside, partially outside angiomyolipoma. No through transmission on that one, but these are very vascular. Once again, the channels are so small that the theory is, like I explained before, that sound just kind of more or less bounces around in there a bit, creating a higher echo than expected. Okay, so now we finally talk about actual renal cell carcinoma. Most common malignant tumor of the kidney, men more than women. Multicystic diseases have a higher incidence. So polycystic kidney disease, von Hippel-Lindau, tuberous sclerosis, acquired disease caused by many years of dialysis. All of those increase the chance of someone getting renal cell carcinoma. And you can see it would be very large, but this one's really isoechoic. You know, the only thing that really strikes me is that when you put color on it, it really goes around. So it's definitely having a mass effect on this kidney. very round, so it's less likely to be a dromedary hump. Sorry. Where am I? This one over here, more echogenic. This one here. Okay, it's the whole, yeah. Okay, there's normal kidney down here. A little bit of hydronephrosis caused by the size of this tumor. The tumor goes from here to here to here to there. So that's a good size hypoechoic tumor. And then we have a mixed, some echogenic tumor, some central fluid in this one. Renal cell carcinomas can be very different. They metastasize easily. They spread into the renal veins. So anytime we're looking at an actual tumor of the kidney, you should always take a closer look at the renal vein as well, and even the IVC, because tumor, once it gets in, just kind of, it follows that vein. Sure, it could stop and go through the side wall of the vein, but it actually tends to follow the vein back to the IVC and sometimes all the way up the IVC. So a varied appearance on renal cell carcinomas from hypoechoic, hyperechoic, small, large, sometimes even cystic. So, and that's pretty much it. Most common malignant tumor, the renal cell carcinoma. The transitional cell carcinoma, not nearly as common. These would be very easy to miss. 90% of renal pelvis and urethral tumors. So ureteral tumors, that urethra is not included in this. It's ureter. That was my bad on that one. So these are difficult to see. If located in the pelvis or in the ureter, then TCC may be suspected. So if we do actually see a tumor here, we can suspect that it is actually TCC. The other thing that this kind of looks like is almost looks like sometimes an infection with you get kind of like a pus ball in the middle of the collecting system. Is not unheard of. Oh. It's over here. Okay. Then there's squamous cell carcinoma. Most of these are actually in the bladder. The book doesn't really mention that because I think we're in the kidney, we're not talking about bladder right now. But squamous cell carcinomas, bladder, they're very deadly. When in the renal pelvis, it is oftentimes associated with calculi. And to tell you the truth, this image is actually transitional cell carcinoma. I could not find for the life of me a actual squamous cell carcinoma image of the bladder. Don't know why. Lymphoma, we've gone through this rodeo before. Local lymph node involvement, it is lymphoma after all, and the lymph nodes are going to be enlarged. The kidney can be enlarged, and typically multiple hypoechoic lesions that can look like cysts. So when we look down here, these are too far out in the cortex to be pyramids. So you think, oh, okay, well, this person has a number of cysts, but there's no through transmission at all. If you look carefully enough, it kind of looks like this is real echoes on the inside rather than just speckle and other stuff going on. This kidney up here, it does appear to be enlarged. I don't know what the measurement is. But we could also see areas of tumor involvement of this kidney. So lymphoma, and like I said before, this is a typical appearance in many organs of what lymphoma looks like. Hydronephrosis can occur we see it with pregnancy all the time. I think the left kidney is more affected than the right. And that's just from the baby pushing down, mass effect on the ureters, and urine has a harder time getting down. But typically with pregnancy, you just have very minor hydronephrosis. Anything that causes polyuria, in other words, you're producing a lot of urine very quickly. Tumors through mass effect can cause hydronephrosis. In other words, a tumor can push down on the ureter. Stones can get stuck in the ureter. And we have basically two types of obstructions. There's the UPJ, ureteral pelvic junction. So this actually, these first three actually, all of them, they look like a UPJ. Something is not allowing urine to pass that point. That could be a stone, it could be a mass, it could be just a stricture, and more often than not, it's actually a stricture right there. Stricture, or as it kind of goes over the psoas muscle, it does get a little squeezed. The UVJ is ureteral vesicle junction obstruction. So that is a obstruction all the way down at the bladder. And obviously, if it's all the way down at the bladder and you have hydronephrosis, then you probably have hydroureter. In other words, the urine is all the way up the ureter and back into the kidney. So obviously, I have different degrees shown here of hydronephrosis. Uroliths, uroliths. I think I put an A in there where it didn't belong, I would assume. Nephroliths, calculi, just kidney calc or whatever you want to call it. Hard to see echogenic stones against an echogenic sinus. Now, this image here, it caught my eye because, wow, those shadowings are beautiful. Except that's totally fake. Those shadows have been drawn in by somebody, but I figured I use the picture anyway. You can not only tell it's fake, that it's not only is it so perfect, but every beam of sound is coming from this point. And if you draw a straight line to these two little echoes from that point, the shadows would actually be traveling more in that direction than straight down. So person didn't even do a good fake on that. But they can't, and of course those are in the parenchyma itself. And most stones, not all, but most stones are going to be found in the sinus, the echogenic portion. So hard to see unless they shadow or twinkle. Increased hematuria, increased leukocytosis, oliguria if obstructive. So this is a realistic image. And even that, yeah, okay, that's probably the stone right there. Little tiny stone there with a little tiny shadow. But you could see just how kidneys oftentimes, and I cannot explain on a normal kidney why it does this dirty shadow, really dirty shadowing that comes off the kidney. And that's disturbing because one of the things we're going to talk about is air in the kidneys, and air creates a dirty shadow. But this is realistic. That's a very good call for this sonographer to even catch that stone and catch that shadow. This stone's a lot easier to find. There's a shadow off it. There's an edge shadow off the kidney. Be careful of those. We're not seeing the top pole very well. And then, well, what the heck is this shadow? And what's this? So there's always a lot. I think there's a lot of edge shadowing within the kidney parenchyma. All these little curves and twists of the calyces cause edge shadowing. So these are a little more understandable. This dirty shadowing, I've looked it up. I've tried to figure out what it is, and I've never really heard anything. There's a great twinkle artifact here. And look at this, the twinkle artifact. You can see the ureter has hydroureter. And you can see the path. Remember how I said yesterday how the ureter comes in underneath, and the weight of the bladder pushing down is what actually keeps reflux, and it keeps urine from going backwards up the ureter. But this would be a UVJ obstruction because the stone is sitting here right at the UVJ, ureteral vesicle junction. I like those pictures. Oh, and renal, I said colic, but it's really renal colic. Pain so bad you want to die. People who have passed stones, women who have passed stones and have also passed babies say the stones were far worse. So let's hope we don't get stones, because nobody wants to get stoned. Staghorn calculus. I think in passing, it's mentioned in the book. It seems like. Then they also mention emphysematous pyelonephritis. And they're going to have a similar appearance in a way. Here's a staghorn calculus. It's literally the entire calyce on the upper pole here is filled with one big stone, and then there's another good sized stone down here in the lower pole, assuming that is upper pole and lower pole. This person had cysts as well. Anyway, what kind of words do I have? I think that's, okay. Given the size of a staghorn calculus, you would think these are easy to see. Now, I picked from the internet a very easy to see staghorn calculus. And it's easy to see because of a very distinct shadow. There's no doubt that this is shadowing. So that should be easy enough to find. Sometimes the shadowing is not so easy to see, or it's so ubiquitous, it goes across the entire kidney. You think, I must not be on the kidney just right. I must be getting a little bit of intestines, duodenum, or the ascending colon must be in the way. So you keep moving your transducer around, and eventually you give up. And even though the staghorn calculus is enormous, relatively speaking, you miss it. So keep that in mind. This is an obvious one. Most of them are not that obvious at all. This one down here is there's something seriously wrong with the parenchyma of this kidney as well. But this is emphysematous pyelonephritis. And so once again, dirty shadowing, except this time we can clearly see what's causing the dirty shadowing. Oh, I wish I didn't do that. All right. So air can be hard to find because we see air all the time. We're always struggling with our kidneys to get away from intestines. And so you see this, if you're not expecting it, you could think, oh, dang it, I still have that intestine. I still have all that intestinal air in the way, and I can't get a clean shot of the kidney. And even your radiologist can be fooled by this. So you have to work really hard to catch those types of things. All that shadowing can create a confusing image. Let me grab a bunch more. There we go. Okay, nephrocalcinosis. I mentioned this yesterday, but I was smart enough to shut up. Unfortunately, I was correct. It is the evil stepmom of medullary sponge kidney. So medullary sponge kidney can lead to medullary nephrocalcinosis. So remember the medullary sponge had echogenic pyramids, but the ones that we saw so far did not shadow. These pyramids are clearly shadowing. So these are clearly filled with calcifications. So that is, and then down here, same thing. The medullary pyramids are filled with calcifications. However, not all cases of nephrocalcinosis stem from medullary sponge kidney. Couldn't remember what MSK is. Okay, medullary sponge kidney. So nephrocalcinosis is more of a state of being than a specific disease. You know what I mean? It's it's like calcifications in general. You have calcifications, but there could be different reasons you have calcifications. Same thing with nephrocalcinosis. So, cortical nephrocalcinosis. This is we don't see this too often. Actually, I don't see nephrocalcinosis period very often. I see medullary sponge kidney a lot. I don't see either of these or any three of these. This is a cortical version of nephrocalcinosis, not at all related to sponge kidney, because it's in the cortex. These are sponge kidneys down here that became calcified, so they became nephrocalcinosis. Cortical nephrocalcinosis, hyperparathyroidism. The parathyroid is a organ behind the thyroid that controls, calcium balance. Vitamin D intoxication. Not a problem with me. My vitamin D is way too low. Acute cortical necrosis. So acute meaning all of a sudden the cortex is dying. Acute cortical necrosis can create a lot of calcifications up there. Glomerular nephritis, a itis, an inflammation of the glomerula, and certain cases of AIDS nephropathy can cause that as well. AV fistulas are most likely caused post-biopsy. Remember, arterial venous fistula. Doctor came in, stuck a needle to do probably a biopsy on something is the most likely cause. And he went through an artery, through a vein. They're now communicating. And so we have this large cystic area, which is actually fills with fluid, with blood. And supposedly they put a pulse wave on this and they found our pulsatile venous flow. Pulsatile venous flow inside of this. Same thing down in the other one. Where's pseudoaneurysm? It must be after this. All right. Hematomas, of course, we can get a good kidney punch, create a little bit of a bleed, varied appearance based on the age. So, so sometimes blood can be echogenic, especially if it's new-ish blood. So that's a bleed inside of the kidney there. Down here, we have a bleed on the upper pole of the kidney. It's hard to see anything, but that's more of a hypoechoic. We have two subcapsular bleeds here. That's a subcapsular, and this one's that's a little more anechoic, and this one's a little more mixed echogenicity, which just tells me they're different ages of hematoma. So blunt injury, biopsies can cause hematomas. In a spontaneous bleed, although a totally spontaneous bleed would be very unusual, there's pretty much always going to be some kind of underlying condition, like a tumor. So renal cell carcinoma, and then suddenly the kidney's bleeding. The tumor itself caused the bleed. Segmental renal infarction, and in fact, I'm sorry, that one down here was an infarct. So basically, this whole end of the kidney does not have a blood supply anymore. There's my pseudoaneurysm. Once again, likely after biopsy, except for rather than an AV fistula, which sends arterial flow into a vein, here we have an artery that's been pierced and the blood got out, but it can only go so far. So basically 1 centimeter across, 1 centimeter high. It can't get any bigger, but it does have the yin-yang sign of the typical pseudoaneurysm. Okay. So here's the thing, guys. I feel like I'm passing a kidney stone. But it's not a stone. I just hurt my back, and so I took some nighttime PM Motrin, and I'm literally doing everything I can to not fall asleep. And literally, I almost feel like I'm going to pass out right now. So I am done for the day. I encourage you guys to read, study, get your homework done, do all that stuff. I got to go lay down because I really don't feel well. So I know PowerPoint days, at least I suspect, are